Hello everybody, I am Elalfy, lecturer of surgical oncology. Today we talk about pancreatic, exocrine and endocrine tumor. Pancreas is made up of two types of glands, exocrine, which secrete pancreatic enzymes, and endocrine, which is islets of Langerhans. We start by pancreatic adenocarcinoma, which is the tumor of the exocrine part. What about risk factor? Related to cigarette smoking, high protein and high fat diet, increased BMI, chronic pancreatitis, diabetes, and occupational exposure to amines. As regard to clinical presentation, abdominal pain, painless jaundice, pruritus due to biliary obstruction, anorexia, steatorrhea due to pancreatic duct obstruction, weight loss, diabetes, acute pancreatitis, malignant ascites, and gastric outlet obstruction. What about my approach to investigation? We start by radiology. We may need to do ultrasound, pancreatic protocol CT, MRCP, percutaneous transhepatic cholangiography, PET scan, or CT angiography. This CT angiography clarifies pancreatic head carcinoma and its relation to major vessels, which is the hepatic artery and superior mesenteric artery. After radiology, we need endoscopy, which is ERCP, endoscopic retrograde cholangiopancreatography, which is utilized to detect small tumors, which is not visualized on CT, palliating stenting for biliary obstruction, and parasitology for pathology confirmation. We may need also AUS, endoscopic ultrasound, which is utilized to detect the tumor itself and obtain tissue biopsy. It is very important in pancreatic adenocarcinoma, endoscopic ultrasound. As regards the blood test, we do amylase level, bilirubin level, serum tumor marker, which is cancer antigen 19-9, and immunohistochemistry for pathological confirmation. As regards the treatment, at the time of diagnosis, only 15 to 20% of patients have localized and resectable tumors. Whatever, 40 to 45% have localized tumors that are unresectable due to vascular invasion, and 40% have distant metastasis, which is inoperable. Option for treatment: if the tumor is localized, we can do radical pancreatic resection plus or minus post-operative radiation or chemotherapy. If the tumor is locally advanced, we can give chemotherapy and radiation. If the tumor is metastatic, we give chemotherapy, gemcitabine. What about surgical procedures? If the tumor is localized to the head of pancreas, we can do either of Whipple operation, which is pancreaticoduodenectomy, which is the most important operation for pancreatic adenocarcinoma, or pylorus preserving pancreaticoduodenectomy, or total pancreatectomy. If the tumor is localized to the tail of pancreas, we can do distal pancreatectomy. If it is localized to the body, we can do distal and removal of the body of pancreas. Also, we can do palliative surgical treatment, which is surgical bypass, gastrojejunostomy, or hepaticojejunostomy, or choroidicoduodenostomy, or cholecystojejunostomy. This diagram illustrates the steps of Whipple operation, in which we remove the head of pancreas, the whole of the duodenum and pylorus, the gallbladder, and the common bile duct, and we reconstruct by doing multiple anastomosis, just like pancreaticogastrostomy and choledochojejunostomy, and finally gastrojejunostomy. As regards prognosis, overall survival rate is 4% for patients with small cancers less than 2 cm with no extension beyond the capsule. Complete surgical resection has a 5-year survival of 18 to 24%. For patients with advanced cancer, 5-year survival is about 1%. And now, what about pancreatic endocrine tumors? Pancreatic neuroendocrine tumor is one of the apodoма tumors of Abbott cells, amine precursor uptake and decarboxylation. Pancreatic neuroendocrine tumor is either entopic or ectopic. Entopic if they produce hormones normally secreted by pancreas, like alpha cells glucagonoma or beta cells insulinoma. Ectopic such as non-beta cells which secrete gastrin, called gastrinoma. As regards insulinoma, it is the commonest endocrine pancreatic neoplasm. It arises from the beta cells of Langerhans. The tumor is usually benign, 90%. It is a part of main type 1. The specific feature of insulinoma is the secretion of excess insulin. Clinical picture of insulinoma is Weibel triad, which consists of symptom of hypoglycemia. During attack, the hypoglycemia below 50%, the symptom is relieved by glucose intake. As regards investigation, either laboratory or radiological, laboratory manifested by hypoglycemia, and radiological either CT or MRI. As regards treatment, the main line of treatment is surgery. If it is localized and resectable, we resect the tumor. If it is metastatic and also resectable, we do resection and metastatiectomy. If it is metastatic and non-resectable, we give lanreotide. As regards the gastrinoma, which is the second most common pancreatic neuroendocrine tumor, is the tumor of non-beta cells. The tumor is usually malignant, and it is a part of main type 1. The specific feature of gastrinoma is hypergastrinemia, which is resulting in intractable peptic ulcer. As regards the clinical picture of gastrinoma, it is intractable peptic ulcer, which characterized by resistant ulcer to treatment, recurrent or multiple ulcer, ulcer in unusual site such as the duodenum and the proximal jejunum, ulcers at the extreme of age. As regards investigation, either laboratory or radiological. The treatment of gastrinoma is like insulinoma. The main line is surgery. We do resection according to the site of tumor. If the tumor is at the head or ancillary process of pancreas, we do pancreaticoduodenectomy. If it is in the center, we do center pancreatectomy. If it is at the distal or tail of pancreas, we do distal pancreatectomy. Multiple endocrine neoplasm, which called Min syndrome, we have two types. Min type 1, it consists of adenoma of 3 P's, pituitary, parathyroid, and pancreas. Hyperparathyroidism is the most common manifestation. Min type 2, either 2A or 2P. 2A consists of medullary carcinoma of the thyroid, pheochromocytoma, and parathyroid tumor. Min type 2P is like 2A plus morphonoid feature. And finally, thank you.